All right, good afternoon, everybody, and happy Colorectal Cancer Awareness Month. I would really like to thank all of you for attending the first installment of the American Indian Cancer Foundation's Lightning Webinar Series. The webinars in this series will be only 15 minutes long and are intended to provide a brief overview. And so due to the short duration and to respect your time, there won't be any time allotted for question and answer. So during the webinar, if you have any questions, you can type your question in the chat box or send an email to health@acaf.org. And we will be sending a follow-up email answering your questions and then providing a recording of this webinar and a brief survey. And I'd really like to thank the Clinic and Community Health team as well as the Urban Cancer Solutions Program for helping create the content that I will be going over today. I'm Michelle Edelman, the Clinic Systems Coordinator at AICAF, and I will be presenting today. And so today we will take a look at stool testing as a strategy to increase colorectal cancer screening rates. And quickly we will do a poll to see how familiar everyone is with stool testing. So I'll give you a few seconds to go ahead and complete the poll. All right, so it looks like most of you are somewhat familiar with the, it's up here. Yep, with the stool testing. So we'll get right into things now. Maybe. Okay, so starting off, why is it important to screen for colorectal cancer? Well, this year it's estimated that 140,000 people in the United States will be diagnosed with colorectal cancer and 50,000 will die. And screening is important, especially for this type of cancer, because it can take 10 to 15 years for a polyp in the colon or rectum to become cancerous. And that gives healthcare providers a window of opportunity to treat patients to remove the polyp or polyps before they become cancerous. And screening is also much less costly than cancer treatment is. But there are increased risks of colon cancer associated with people of minority races or ethnicities. And this is especially prevalent in American Indian communities. And among American Indian women and men, colorectal cancer is the #3 cause of death and #2 cause of death, respectively. And while every other population has experienced decreasing mortality rates over the last 20 years, American Indian rates are remaining steady or actually increasing. And in addition, as of 2016, only 39.6% of IHS service population was up to date with their colorectal cancer screening. And this graph shows that American Indian and Alaska Natives and several IHS regions have a higher incidence of colorectal cancer compared to non-Hispanic whites in the same regions. Alaska, Northern Plains, and Southern Plains have a much higher age-adjusted rate of colorectal cancer, and lower rates can be found in the East, Pacific Coast, and Southwest regions. And here we have the USPSTF, or the Preventative Services Task Force screening recommendations. And so an individual would be considered at average risk for colorectal cancer if they have no family history of colon or rectal cancer. So screening would be between the ages of 50 and 75. But if an individual is above the average risk, this would mean that they had a parent or sibling with polyps or cancer before the age of 50, or they have 2 or more relatives with colon cancer at any age. Screening should begin at age 40 or 10 years younger than the relative was at the diagnosis of their cancer. And some health professionals believe that American Indian individuals should begin screening at age 45 due to being at higher risk for colorectal cancer. And for Alaska Natives, age 40 is already promoted and used. And at AICAF, we do support the 45-year-old recommendation for screening. And there are 2 main ways to screen for colorectal cancer using direct visualization tests such as colonoscopy, sigmoidoscopy, and CT colonography, as well as at-home or stool-based tests. There is limited screening is likely contributes to the colorectal cancer disparities faced by American Indian populations. There are multiple stool tests that currently exist for colorectal cancer screening that can be easily distributed to address a lack of colorectal cancer screening among those who are candidates. These are the fecal occult blood test, or FOBT, the fecal immunochemical test, or FIT, and stool DNA. And these are lab tests used to check stool samples for hidden occult blood. So going into more detail about these stool tests. So the FOBT test looks for the presence of blood throughout the entire GI tract. It uses guaiac chemical to detect blood, so therefore you must avoid certain foods such as red meat. And this test must be completed every year to be effective. And then next we have the fecal immunochemical test, or FIT, and this is more specific to blood in the colon. It uses antibodies to detect human hemoglobin. And there is increased patient adherence for this because there is no dietary or medication restrictions. And for FIT testing, there are many brands available, and there's not really any consensus that one brand is better than the other. And finally, in order to be effective, it must be completed every year. And then in addition, stool DNA tests have become available within the past few years. And this type of test looks for certain gene changes that are sometimes found in colon cancer cells, or they look for DNA changes that could indicate precancer or precancerous polyps. And then it also checks for the presence of blood in the stool that can indicate cancer. And just like the FIT test, there's no special diet or bowel preparation required. And this test only needs to be completed every 3 years. And in all stool test cases, if there are abnormal findings, a colonoscopy will need to be completed. And then this chart was created with findings from AICAF's Impacts project that was assessed. They assessed around 50 clinics in the Northern Plains regions, and provider recommendations of specific colorectal cancer screening options varied across the clinics. But as you can see, colonoscopy is the most frequently used and recommended screening test for colorectal cancer. Screening recommendations are often based on availability, cost, ease of use, and other contributing factors that may limit options to recommend to patients. And even while there are multiple options available at a clinic, people still believe colonoscopy to be the gold standard. Stool testing is often overlooked as an effective screening option that must be shared. It's important to recognize that patients may be more inclined to choose stool testing over colonoscopy. And when stool tests are provided annually to average risk patients with appropriate follow-up, stool occult blood testing with high sensitivity can provide similar reductions in mortality when compared to colonoscopy and reduction in incidence. And then I want to emphasize that digital rectal exams, or DREs, are no longer an acceptable way to screen for colon cancer. As research has shown, the exam misses more than 90% of colon abnormalities, including most cancers. And here's just a quick screening guideline, because it's important that healthcare providers are aware of the timelines for the various tests that can be used for colorectal cancer. And so as many of you are aware, colonoscopies only need to be completed on average every 10 years. And direct visualization tests have a longer period between testing than stool testing. And I really want to emphasize again that the FIT and FOBT stool tests need to be completed every year to be effective, while stool DNA tests only need to be completed every 3 years. And currently, there's only one FDA-approved non-invasive stool DNA screening test for colorectal cancer, and it's only available by prescription. This test offers people 50 years of age and older who are at average risk for colorectal cancer an easy-to-use screening test, which they can do in the privacy of their own home. This test is designed to detect DNA alterations and blood release from cancer and precancerous colon lesions, and has been proven to find 92% of colorectal cancers in average risk patients with a specificity of 87% using only a single sample. This type of testing also finds more cancer cases than the FIT test, according to a clinical trial that tested over 100 people. And this test does not require medication, dietary restrictions, or bowel preparation prior to taking the test. And now that we've covered the types of possible stool tests, I'm going to go over 3 evidence-based strategies that are shown to help increase colorectal cancer screening rates among patients. And these are shared decision-making, stool test awareness, including demonstration, reminders, small media, and incentives, and then the FluFIT FOBT implementation. And so providers must create buy-in for patients by giving them a choice of screening test or method, This includes explaining both the direct visualization exams and the simpler take-home stool tests. And it's important to let their patients have a choice for their test when their circumstances allow it. In some instances, the patient may only be eligible for colonoscopy due to family or personal history, but for those individuals who are at average risk and a candidate for stool testing, it's important to share those options with them, including the pros and cons. And then next we have stool testing awareness. And the magnitude of a clinician's impact is really considerable. Surveys have shown that 90% of people who reported a physician recommendation for a colorectal cancer screening test were screened, versus only 17% of those who reported no provider recommendation. And 72% of those whose physician recommended a stool blood test completed it, versus 8% of those whose physicians had not. And so doing a walkthrough or a demonstration of the stool test can really help patients understand what a stool test is and what they can expect. And of course, once the patient leaves the office, they may continue to require cues to action to complete their screening, both at home or in the clinic environment. And so ideas for this include contacting patients in need of preventive services for the following month, utilizing multiple reminder methods, sending a stool test kit in the mail in anticipation of a visit, and then making sure to use discreet packaging, providing outreach, hanging posters and flyers, and PSAs from community advocates. And at AICAF, we have developed several educational materials that you can find on our website at aicaf.org/colon. And this is an example of an incentive program for screening using a prominent figure in the community. At the American Indian Cancer Foundation, we have implemented the Refer a Relative program. And this is for American Indians age 50 and above, and they can receive a $20 gift card after completing a colon cancer screening. Anybody can refer to American Indians and receive a $15 gift card per person who completes their colorectal cancer screening. And all relatives that complete their screening will also receive a $20 gift card. And another example is, this is Robert DeJarlett from the Red Lake Band of Chippewa. He first announced his colon cancer diagnosis by stepping out as a survivor at Powell for Hope in 2013. And since then, Robert has been a fierce advocate as a cancer educator, raising awareness as he tells his story. He talks about his cancer story to encourage others to get screened. He says that it's interesting that there are more and more people with cancer, and that it floors him with what's going on. And he believes that if everyone got tested and screened regularly, we wouldn't see these people get cancer. And then the third strategy to help patients get screened for colorectal cancer is implementing the FluFIT or the FOBT program. And these are evidence-based programs that allow clinic staff to identify eligible patients and offer home stool tests at the time of their annual flu shots. And coupling colorectal cancer screening with established annual flu shot activities can be an excellent way to introduce the importance of colorectal cancer screening to clinic teams and patients, and have been shown to improve screening outreach. And today we covered the option of stool testing, but I really want to emphasize that the best colorectal cancer screening for a person is the one that does get done. And I just want to thank everybody for joining today. And if you have any questions, please contact us at health@aicaf.org. And make sure to join us next Thursday, March 29th from 2:30 to 3 p.m. Central Time for a very special live Facebook event with AICAF's own colorectal cancer expert, Joy Rivera. She'll be answering your questions and providing a stool test demonstration. And be on the lookout for a follow-up email that will include slides and a recording of today's presentation. And shortly we will be posting, there has been a question or a survey posted in the chat box. If you could go ahead and please take that. And thank you for attending.